Huh? Okay. Now you see that lungs, of course, lungs are big, spongy parenchymal organs, well vascularized by double circulation. So these big parenchymal organs, not only do they have their own malignancies and they send the malignancy elsewhere as metastasis, they are also likely to be receiving malignancies. Okay. So lung of course is a big organ, and it does receive a lot of metastasis from other organs as well. Okay, so out of the lung malignancies, lung and liver, these are the organs in which you have to consider that this possibility. Whenever you get a FNAC or cytology or histology, you also have to think whether it can be metastasis, not just primary, because these are big parenchymal organs with good vascular supply, and there is a possibility of receiving shower of emboli from the other primaries. Okay, so metastasis is also quite common. Okay, not just the primary. So we will first read about primary lung carcinomas and also a word about which are the organs likely to send metastasis to the lung. So what are the organs which are likely to send metastasis to the lung? Starts from thyroid, starts from breast. Okay, breast is likely to send a shower of emboli also going to the lung, and thyroid is very important. Below the diaphragm, liver of course can send, and so many other, not just the carcinomas. These are the carcinomas: the thyroid carcinoma and the breast carcinoma and the liver malignancies, the hepatocellular carcinoma, and now so many others. This is just an endless list. Okay, so these are the ones which are also likely to send. Okay, emboli of metastasis from their primaries to the lung. Okay, and lung, of course, the major part is the carcinoma. The 95% of all the malignancies that we get from the lung, we first have the clinical suspicion index is high for a carcinoma, and more often than not, our pan-CK marker will turn out to be positive, even if it is very poorly differentiated. Not just that, there are also other malignancies which are primary in the lung, and that is what we are talking about. These are the 5% of other primary malignancies of the lung turn out to be carcinoids. Carcinoids are neuroendocrine. The carcinoids are benign end of the neuroendocrine spectrum, and then you have the poorly differentiated part of the neuroendocrine spectrum and the high grade part, which is the neuroendocrine carcinoma. So I told you that the major of the lung primary, 95% of the major primary lung cancer, it is the carcinoma. Of all the primary lung tumors that we keep receiving, mass, well-defined mass or something which is looking very clearly mass-like, we do get a biopsy. We do get a lung biopsy. Nowadays, lung biopsy is not as uncommon as before. There are so many places in which the lung is quite amenable to biopsy, and even the most inaccessible sites also, they do a bronchial wash and they try to drain out the falling cells from the tumor, and they try to give it to us. So whatever cases we get as diagnosed as big masses which look like primary, almost 95% of them are arising from the bronchial epithelium, and they are the carcinomatous masses. And around only 5% are bronchial carcinoid, the miscellaneous ones, the soft tissue ones, the fibrosarcoma and the leiomyosarcoma, and then some of them are lymphomas, and then of course some of them are the benign lesions of the connective tissue there, like chondroma, and sometimes you get these cartilaginous chondromas and chondromas, which are very benign. Okay, so these are the, sometimes you even get hematomas in the lung, a combination of various elements, mesenchymal elements in the lung. So you get some of these lesions also as well, okay, which is like the rest of the 5%. So most of them are carcinomas. So let's first talk about the primary carcinomas of the lung. So lung, as I told you, is a big spongy organ, and the carcinoma will get to grow before it actually produces a symptom. It produces a significant hypoxia or a compression effect, or produces atelectasis, that is collapse of the distal portion, or whether it is causing bronchiectasis, that is the stagnation of the secretions draining from a nearby bronchi. So it will grow to a larger size to produce symptoms. Therefore, the carcinomas become very aggressive, and it becomes sometimes a very late stage at the time of diagnosis. So this is a big pitfall unless you actually have a family history and you have a tendency to undergo investigation. and you have very high index, so even for the slightest cough. So I tell you, even for big celebrities also, they present at a later stage, when already the cancer has become too big and unresectable, and probably just stage 3 onwards only chemotherapy and radiotherapy can be given. So peak incidence of lung cancer generally in the 50s and the 60s, and a diagnosis more than 50% of the individuals have distant metastasis. So that's what I was saying. This is the big pitfall of these parenchymal organs. The cancer gets to grow up to a larger size before it actually compromises the system and presents as clinical features. So at the diagnosis, more than half of the individuals already have a metastatic disease that is already stage 3 or 4. The prognosis is dismal, therefore, and the 5-year survival is only about 15% in the best of centers. Even those with disease localized to the lung have a 5-year survival. If you say stage 1 and stage 2 also, the 5-year survival is not that great. It's only 45% because lung, of course, is an important organ, and it does compromise it does cause a lot of morbidity and may cause mortality due to the severe effect. Major histologic types of lung carcinoma. Okay, so now we are talking about that 95% of all the primaries are carcinoma, and then of course the major histologic types are the squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and the large cell carcinoma. Sometimes you get a question on oat cell carcinoma. Oat cell is nothing but small cell carcinoma. The nucleus is so big that it looks like oat-eyed, oat type, round. Okay, so oat cell carcinoma is nothing but small cell carcinoma. So don't be baffled if you get a question on oat cell carcinoma. The West has a tendency to put these fancy names. Squamous cell carcinoma. This is the most important lung carcinoma, most common lung carcinoma in the Southeast Asian countries. But then you always hear that adenocarcinoma is the most common variant of lung carcinoma, and that is pertaining to the studies in the West. Here, squamous cell carcinoma in the Southeast Asian countries, squamous cell carcinoma is the number 1 carcinoma of the lung. So when you hear something like adenocarcinoma is the most common primary lung tumor, it basically refers to Western literature. Large cell carcinoma. What is a large cell? Large cell is the anaplastic carcinoma, which was usually considered as a wastebasket category when the differentiation and high-grade also tumors were put into it. Now in the era of IHC, sometimes in the large cell carcinoma, you try to put all the IHC markers, you may get some squamous markers positive, you may get some markers, small focal area of adenocarcinoma markers positive. So, largely it refers to the undifferentiated or the anaplastic look on morphology. Sometimes you may get foci which look like adeno, which look like a squamous differentiation, which look like neuroendocrine. So it's basically the high grade stage or the progressive stage, or the carcinoma has not got diagnosed for a long time and the patient has grown very long. So it looks like an anaplastic, undifferentiated large cell carcinoma. Okay. So adenocarcinoma is the most primary tumor, especially in women. So even when you talk about Southeast Asian countries, which is the most common cancer in women, because here also in Southeast Asian countries, the pattern is that squamous cell carcinoma is the number 1 in males in the lung. Squamous cell carcinoma is the number 1 in males. In females, which is the most common cancer in females, breast. But then followed by lung, and in lung it is the adenocarcinoma variant which topples the squamous cell carcinoma, even in females of the Southeast Asian countries. So, adenocarcinoma is the most common primary tumors arising in women in lifetime non-smokers. So there's a keyword. Squamous cell carcinoma is common in Southeast Asian countries because of the crude smoking habits, hookah, smoking, then so many other pollutants also combined into the picture. So in lifetime non-smokers, it's said that adenocarcinoma is more common even in Southeast Asian countries. Otherwise, by and large, squamous cell carcinoma is much more common in the males and smokers of Southeast Asian countries. Okay, so and in persons younger than 45 years, so it has more familial. Adenocarcinomas are more common in the West because of the familial origin. Okay, the mutations which are coexisting with these carcinomas. So, what do you know about cigarette smoking? So, cigarette smoking has a direct cause effect, and it's a All the experimental evidence collected so far does prove that it is a direct association with cancer. So an impressive body of statistical, clinical and experimental evidence incriminates cigarette smoking as the definite causative agent of lung cancer. So what does cigarette smoking cause? We have heard so far that cigarette smoking causes metaplasty. It causes first erosion of the normal lining, and the normal lining is then replaced by metaplastic epithelium. For example, the tall columnar epithelium, when it gets repeated insults of cigarette smoke, it turns into stratified squamous. Okay, stratified squamous. But if the insult continues, then this metaplastic also becomes dysplastic. The epithelium becomes dysplastic. You can see the larger nuclei, the prominent nucleoli, the anaplastic look, the cells look heterogeneous, they don't look the same. The nuclear stratification of the stratified squamous epithelium becomes disorderly, and then the breakage of the basement membrane when you get the invasive carcinoma. So it doesn't stop at metaplasia if the insult does not stop. It becomes more and more dysplastic and it becomes malignant. So there is a direct cause-effect relationship proven by clinical studies, proven by statistical evidence and experimental evidence. 90% of the lung cancers occur in active smokers or those who have stopped recently. So if you stop recently also, then the toxins of the system does carry it a little longer. There is nearly a linear association, so all sorts of association has been proved in the frequency of lung cancer and number of back years of cigarette smoking. So it is seen with all incriminating statistical evidence. You are seeing that there is what all happens in cigarette smoking is being studied and in other lung cancers as well. So in non-smoking individuals, especially of the East or the Eastern countries of the Far East, you are seeing that the epidermal growth factor receptors, we have studied here also. We have studied the EGFR-related lung cancers of our Northeast also. So non-smoking, especially in the women, the association of EGFR mutation is quite high. Otherwise, you get all sorts of, in the West, you get a lot of KRAS, even in India also, you get a lot of KRAS oncogene activation. And P53, it is the most fatal type. If P53 mutation becomes high grade very fast, and it has a very bad prognosis. Okay, so inactivation of the other tumor suppressor genes located on chromosome 3p is a very early event, and P53 mutation lends a very bad prognosis. So these are the ones: KRAS oncogene, P53, and epidermal growth factor receptor mutations are seen in lots of 3p chromosome mutations of 3p is seen in lung cancers. Passive smoking increases the risk. So cigarette smoke is so much of a agent that not just it causes the bed, it makes a promoter as well as a actual causative agent. Okay, so it causes a fertile bed of multiplying cells. Cells are multiplying and cells are growing, and then there is metaplasia, and then there is dysplasia, and then there is final multiple insults are added to it. All these theories of multi-step carcinogenesis have been depicted in smoking. And needless to tell you that not just the active smokers, the passive smokers of the family also sometimes, they may have a more genetic predisposition and therefore it can present as cancer. So proximity to the cigarette smokers all time also increases risk. Squamous and small cell carcinoma show the strongest association with tobacco smoking. Squamous cell carcinoma and small cell carcinoma also show a little less. They are the best, they are the ones in which direct cause-effect relationship has been seen statistically. Now you see minors of radioactive ores. I was last time talking about some of the occupational lung diseases which are associated with cancer. So in asbestos, I had mentioned that it's the pleural cancer, the mesothelial cancer, which is important. But then, of course, I said a small percentage of asbestos-exposed long-term individuals also have lung cancer. Workers exposed to other toxins, you have to remember, which causes lung cancer: arsenic, chromium, uranium, nickel, vinyl chloride, and the mustard gas. So what was the charge on Saddam Hussein? That he has subjected a large Kurdish population. Kurds are the ones which are the native tribals of the nearby or one of the states of Iraq. Okay, so he had subjected a lot of Kurd population to nerve gas and mustard gas. So as a result, there was, of course, the hit cannot be examined, not in just one generation, but the charges were severe. The charges on Saddam Hussein were severe, and therefore he was finally sentenced to death by the US courts. And then, of course, you see that these are also incriminated in lung cancer. So not just lung cancer, many other cancers, but then one of them is lung cancer, then CNS cancer, then thyroid cancer, so many of these. And then you have seen that arsenic, chromium, uranium, nickel, vinyl chloride, and mustard gas, all of them have a association with causation of lung cancer. Exposure to asbestos increases the risk even in non-smokers. So it increases, at least the risk is fivefold in non-smokers, and in heavy smokers the risk is multiplied 11 times more, that is the 55-fold greater risk in smokers associated exposed to asbestos. Long-term exposure to asbestos and 55 times higher greater risk than compared to non-smokers. As compared to non-smokers. So can you understand? So far, can you understand the lung carcinoma? What is the picture? Now morphology. Lung carcinoma.
Yes, ma'am.
Good. So, lung carcinomas of the lung begin as small mucosal lesions that are usually formed and gray-white. Just like all the cancers, the epithelial growths are more of gray-white in gross appearance, and they are not stained, they are not subjected to any staining, no cutting, no sliding. The gross appearance is gray-white. It's like generally the whitish, the pearly whitish in squamous cell, and the gray-white and very firm appearance. It becomes firm and then it becomes hard as time progresses, because it causes a lot of fibrosis in the desmoplasia, that is what we call. So the carcinomas, they grow as white nodules, and then the pattern is invasive also. It becomes more invasive later on and becomes firmer and firmer as time progresses. It becomes hard later. So they begin usually as mucosal lesions. So they will be somewhat connected to the epithelium, the normal epithelial areas. It will have a bronchial predisposition, or it will have a acinar predisposition. So the epithelial lined areas will be actually the incriminating originators of these carcinomas. So as and when you see, they will be connected to some nearby epithelial structure. They form these intraluminal masses. They protrude into the lumens of the epithelial line structures, and they invade the. Then they of course grow as they expand. They will destroy the bronchial mucosa, and they will form the large bulky masses which will grow into the adjacent parenchyma. So these spongy organs cannot give enough space for the tumor to grow bigger before the presentation actually comes. May extend into the nearby pleura. It grows so much so that it invades into the pleural cavity as well as sometimes the chest wall and into the adjacent interthoracic structures, adjacent muscle, adjacent nerves, adjacent connective tissue is also invaded, not just in the lung parenchymal region, it grows outside as well, or connective tissue of the outside as well and inside as well. So it gives a lot of area, space for the tumor to grow before it becomes clinically presentable. Within no time, the tumor grows. The carcinomas are very aggressive. More distant spread occurs via the lymphatics and the hematogenous roots. So lymphatic and hematogenous root gave a wider area for the tumor scope to disseminate, to metastasize. So now squamous cell carcinoma, if we talk about squamous cell carcinoma, more common in men than in females, associated with more often there is a history of smoking. They arise centrally in the major bronchi and spread to local hilar nodes. So they arise generally in the epithelial line major bronchi. So squamous cell carcinoma is more common in the central areas, centrally located. Adenocarcinomas both centrally and peripherally located. Adenocarcinomas more centrally and peripherally located, both centrally. Small cell carcinomas both centrally and peripherally located, because you have the Kulczynski cells from which they arise. From the bronchial epithelium, you have the neuroendocrine cells of the other acinar areas also where they connect, where they grow from. And even for the adenocarcinomas, you have the secreting cells of the acini lining the acini, and you have the cells, secreting cells, very much the goblet cells and the adeno glands sitting in the mucosa and submucosa. So squamous cell carcinomas, more often than not, they are the larger bronchi, because of course the smaller bronchi become that respiratory and adenomatous. So they more often, of course, it can arise from metaplastic and dysplastic epithelium as the insult progresses. So it can be anywhere actually, even in the small bronchi they may arise. It's not that they will just arise from the tracheal area. It may arise from the epithelium which is already damaged, insulted, becomes metaplastic and then dysplastic. So previously columnar epithelium, now it has become replaced by dysplastic stratified squamous. But more often than not, it is always the central area. And they are preceded for years by metaplasia, dysplasia sequence, and the carcinoma in situ sequence. A phase that could have preceded the tumor by several years. Eventually, it reaches an symptomatic stage where a well-defined tumor mass begins in the obstruction of the lumen, and therefore they will produce a either the distal collapse or a distal stagnation or infection. Stagnation of the secretions or infection. So, of course, it produces all that the tumors will produce when it blocks the bronchi. Either it will collapse the distant part, that is atelectasis. Histologically, they are generally the well-differentiated squamous cell carcinoma showing the keratin pulse. When they are well-differentiated, you can see the keratin formation. And the intracellular bridges also are very visible in a well-differentiated squamous cell carcinoma. Cellular bridges, they become more demarcated because the pavementing effect, the cells are flat. It's the pavement-like. Pavement is like the size of the roads. So they are pavemented block by stones like that. So it becomes flattened and it has a well-differentiated squamous appearance. But it can range to a poorly differentiated neoplasm having a minimal residual squamous cell features left, where you have to try and recognize morphologically. Sometimes you may need IHC. So the cytologic features are sometimes recognizable in bronchial lavage or the sputum, and therefore you can, sometimes the tumors may not have been so big to detect in radiology and even asymptomatic clinically, and you have detected on the dysplastic cells in bronchial lavage. So which will be lucky for the patient actually to detect early, because then the surgical resection is also surgical resection, and stage 1 and stage 2 it's more amenable to treatment. Once the progression to stage 3 and 4 happens, prognosis drops drastically. The lung carcinoma you are seeing here, grey-white appearance and rustically uncircumscribed borders, very invasive, rough borders, and the tumor is seen infiltrating the surrounding. When you see this in the cytology and you put subject to, this is a pap smear, characteristically showing the oringophilia of a dysplastic squamous cell. This squamous cell would have been otherwise difficult to identify as squamous, but you're seeing the oringophilia which demarcates the keratin formation of a dysplastic cell, which means it's a squamous cell carcinoma. So this is morphologically very poorly differentiated, difficult to say, maybe squamous, but in the pap smear, these are the bronchial lavage. These are dysplastic cells have come out. So this cluster of dysplastic cells, and in pap smear, this dysplastic cells. There's a routine GIMSA or the Moegrin-Wald GIMSA, and this is the pap smear in which the cytology is showing clear-cut oringophilia, and this is the keratin demarcates the keratin. And you see this keratin pearl, then you say that this is a squamous, this is a dysplastic squamous nest, and it's an invasive squamous cell carcinoma producing a lot of dysplasia. That's a fibrosis. Look at this. This is a adenocarcinoma. This is a squamous cell carcinoma. This is in contrast adenocarcinoma. The glands. This is having abnormal mitosis, a coarse chromatin, and there's a nest, prominent nucleoli. If you see, can you see this much? And this is our neuroendocrine, and it's also known as the small cell. Morphologically, you call it small cell, and then you can put the neuroendocrine markers. If it's neuroendocrine markers, first you look at the small cells molding with respect to each other. They're molding with respect to each other, means they are like fitting as jigsaw puzzles with respect to each other. And this is the azopati phenomena, where near the vessels the neutrophils break. It's a breakage effect, which is generally seen in the small cell carcinomas. Then, of course, there's a large cell anaplastic look. You can't see the proper good features. You know that these cells are just very, very coarse chromatin, lack the glandular features, lack the keratin pearls, lack the high NC ratio, the blue cell look of the small cell. Blue cell tumor. The small cell carcinoma is the blue cell tumor, and therefore it's also known as the oat cell carcinoma. oat cell carcinoma. Adenocarcinomas occur as central lesions and they're usually more peripherally located. Okay, so adenocarcinoma, both I was telling you, central as well as peripheral. Small cell carcinomas, central as well as peripheral location, but the squamous cell have a more characteristically central predilection. So they can be central and peripherally located as well. Adenocarcinomas grow more slowly and they form smaller masses and they tend to metastasize further at an early stage. So the metastasis is more problematic because it has a bigger predilection towards the lymphatics and the bloodstream. Histologically assumes a lot of forms. Sometimes it may look like acini of the native lung, or sometimes it may assume a papillary and more solid appearance. So it may form a papillary grape-like cluster. Sometimes it is more like native, that is the back-to-back acinar gland forming structure. So these are adenocarcinomas. Okay, so adenocarcinomas, the gland-like appearance is recognizable. You call it well-differentiated adenocarcinoma. If the gland-like appearance is unrecognizable, then you call it the poorly differentiated adenocarcinoma. The putative precursor of peripheral adenocarcinomas have been described as atypical adenomatous hyperplasia, AAH. So you have seen that AAH, okay, so this is the, just like in squamous cell carcinoma, I was telling you, it goes through a metaplasia, dysplasia, carcinoma, and C2 sequence. Here they are saying the precursor lesion may have been an atypical adenomatous hyperplasia, which is just the dysplasia which is marked by the basement membrane, limited by the basement membrane. It's like a dysplastic stage, but it's limited by the basement membrane of the glands. And it's not really invasive. The gland has not started invading into the connective tissue. Genetic analysis shows that it's more of an association of KRAS mutations. So I was telling you, KRAS is very common in the West. The KRAS mutation is very common in the West. Of course, we are having a lot of cases here also associated with KRAS. Now you come after this adenocarcinoma, come to the large cell undifferentiated. I told you that large cell carcinoma is a wastebasket kind of a category where you can't distinguish the proper features. You put it into large cell carcinoma, anaplastic, undifferentiated malignant cells that lack the cytological features of small cell, glandular, or squamous differentiation. So this is the large cell category. Large cell category is the wastebasket category when you can't identify the small cell carcinoma features or the squamous differentiation or the glandular differentiation. So are you guys following so far? This is the undifferentiated anaplastic carcinoma.
Yes, sir.
Cells typically have large nuclei, prominent, very anaplastic coarse look with prominent nuclear borders fraying away, nuclear borders not so smooth. Now the nuclear border, nucleus is showing a lot of atypia, chromatin is coarse, hyperchromatic, prominent nucleoli, and cytoplasm becomes scant, but the cells are large. So you won't say that cytoplasm is as scant as a small cell carcinoma. There is a moderate amount of cytoplasm. Small cell carcinoma, you use the word scant cytoplasm. Absolutely. Nucleus is predominating the look. So blue cell look in the small cell carcinoma comes. Here, moderate amount of cytoplasm. You use that word. Large cell carcinoma represents probably an undifferentiated or a progressed stage of small cell, of squamous cell and adenocarcinomas that are so undifferentiated that they can no longer be cannot be recognized on light microscopy. Ultrastructurally, however, sometimes you may see some glandular and squamous foci. You may see some glandular, and even on IHC, you may see a foci of glandular and squamous differentiation. So if you do see a recognizable foci, you try to report because that will guide the treatment of the clinician. He will try, otherwise large cell carcinoma is very non-amenable to treatment. But if you do see a adenomatous or a squamous foci, you try to give the treatment for adeno and squamous cell carcinoma, whichever you see. Now, small cell lung carcinoma. So this is another. Basically, you even in FNAC you try to categorize into small cell and large cell. So in the large cell carcinomas, you have these categories: squamous, adeno, and large cell anaplastic. Even on cytology, and you put it as small cell carcinoma, you mean that they can be a neuroendocrine or a non-neuroendocrine small cell carcinoma. So basically on morphology, you put it as small cell carcinoma, you try to put the neuroendocrine markers. Some 10% of the small cell carcinomas might show the neuroendocrine marker positivity. So these are either centrally located or they are peripherally located. They may even go as rise as small nodules in the periphery. Usually centrally located masses with extension into the lung parenchyma and involvement of hilar and mediastinal nodes. So I told you that in the bronchial mucosa, the Kulczynski cells are the precursors. So sometimes you are asked what are the neuroendocrine cells sitting in the bronchi, which are the precursors of small cell carcinoma. So pale grey, centrally located masses, extension into the nearby parenchyma, that happens for all the carcinomas, and involvement of the hilar and mediastinal structures, lymph nodes are involved. Was composed of tumor cells with scant cytoplasm, and the chromatin will not be so coarse, but it will be hyperchromatic. And cells will be fitting into each other. So that is the jigsaw puzzle-like appearance is known as nuclear molding is seen. Nuclear molding is seen. And mitosis may also be seen. And these are the cells of with size 2 to 3 times the cells of the neighboring lymphocytes. So when you see the scattered inflammatory cells in the vessels and nearby, you try to compare. The cells will be looking hyperchromatic, malignant, prominent NC ratio, and twice the size of resting lymphocytes. Necrosis is also present. I showed you in the picture, necrosis is present and may be extensive. So I showed you that the necrosis effect is also there. The cells are very amenable to smudging also. When you put in the cytology picture, cells get broken very easily. Small cell carcinomas are very prone to smudging and necrosis. Esophagy phenomena, where the neutrophils, their cells, the cells infiltrate the vessels. They can be seen peeping into the vessels. So that's the esophagy phenomenon. So, we were talking about small cell carcinomas that are twice the size of the neighboring lymphocytes, if you see. The tumor cells are fragile. So I was talking about this, they're amenable to crushing. They are having a crush artifact in small biopsy specimens. So this crushing is actually called an artifact. The crushing and the breakage effect which you see in small cell carcinomas. The cells show fragmentation. Nuclear molding is an important recognizable feature because the cells have scant cytoplasm. The nucleus tends to be molding with respect to each other, and they fit so nicely that the whole thing will appear blue, sheet-like. Then derived from the neuroendocrine the cells, I told you origin is from the neuroendocrine cells of the lung. These neuroendocrine tumors, more often than not, are associated with expression of some polypeptide like precursor or a polypeptide hormone or a hormone-like precursor, and therefore it produces what is clinically called the paraneoplastic syndrome-like picture. Now it abnormally starts elaborating a cell, elaborating an hormone or an enzyme which does not resemble, there is no characteristics like that in the native cell to produce that, but it will start elaborating ADH-like hormone. Syndrome of inappropriate ADH is a paraneoplastic syndrome associated with oat cell carcinoma. So I told you oat cell carcinoma, the West says oat cell carcinoma for this small cell carcinoma. It is associated with this kind of tumors. Other elaborating hormones as well. So I told you this is associated with, classically the lung small cell carcinomas are associated with a lot of paraneoplastic syndromes, because they elaborate some hormones or enzymes which will produce that clinical picture. General considerations, involvement of the left supraclavicular node. Now, this is the general of the lung tumors. The lung tumors present the metastasis to the left supraclavicular lymph node, that is the Wertko's lymph node, and it is positive and hard, and suddenly the supraclavicular lymph node is positive, and there is no other feature, and the patient gets alarmed and he comes to the clinic. You do an FNAC, you see that there are large anaplastic cells and there's a hard lymph node, and you say that there is an occult primary tumor, and more often than not, it's either in the chest or in the intra-abdominal organs. So it might be as down as the testes also. So there are so many sites of stomach, testes, breast, lung, which sends metastasis to the Wertko lymph node or the left supraclavicular lymph node. So you try to do a scan, you try to do a PET scan if there is a bigger problem and you cannot identify, then you get the site of the occult primary tumor. Sometimes the tumor may be hidden in the retroperitoneal renal cell carcinoma, and it has sent an emboli, and the patient is alarmed because there's a hard lymph node in the supraclavicular area. that is known as the left supraclavicular lymph node positivity, or the Burko's lymph node. And Burko diagnosed this sign as positivity or metastasis for an occult primary located intra-abdominally or in the chest, and even as far as the testis and the genital organs. Often extend into the pericardial pleural spaces, and of course lung tumor can become very notorious, goes into the pleura, pericardium, and it causes a lot of lung effusion. Now, and more often than not, advanced stages presents as peritoneal, pericardial and pleural effusions. They may infiltrate the superior vena cava and cause, so this supervena cava compression syndrome, and this is the full-blown venous congestion syndrome. And it is known as it is because of the Pancoast-like tumor, or it's the squamous cell carcinoma compressing the superior vena cava. So apical neoplasms that invade the bronchial, cervical, sympathetic nerve system to cause severe pain in the ulnar distribution of the nerve. Ulnar pain is known as the Horner syndrome. What is the Horner syndrome? There is ipsilateral anophthalmos, the eye is sunken. There's otherwise there's ptosis, meiosis, all sorts of syndrome, because the tumor is located apically and it bulges into the clavicular sympathetic plexus. Cervical sympathetic plexus is compressed. Brachial or the cervical sympathetic plexus, the originating area in the cervical area, is compressed by the apically located squamous cell carcinoma of the lung. Apically located squamous cell carcinoma becomes so big, it compresses the neck or it compresses the brachial plexus. And there is pain in the distribution of the ulnar nerve, as well as symptoms of the central nervous system tumor impinging into the central nervous system. So ipsilateral anophthalmos, ptosis, meiosis, and hydrosis. There's no sympathetic features in the location, and it's most often in the ipsilateral arm. Ipsilateral arm, you get lots of sympathetic system features missing. So that is, you get the feeling that the sympathetic system is compressed by the apical location of the tumor. And this is known as Pancoast tumor. Such apical located tumors are more often the squamous cell carcinomas, and they are known as the Pancoast tumor. And this whole clinical finding is known as the syndrome. The constellation of clinical find is known as the Pancoast syndrome. It is accompanied sometimes with destructive effect of the first and second ribs and sometimes even the thoracic vertebrae are compressed. As well, the cervical ribs as well as the thoracic vertebrae. So the ribs, as the first and second ribs, and the thoracic vertebrae are compressed. As with other cancers, the tumor node metastasis categories has been established to indicate the size and spread of these Pancoast tumors. So they can become very notorious. They will produce an ipsilateral damage in this half of the loss of the sympathetic features. Sweating will go, and hydrosis. So the complete loss of this sympathetic response. Clinical course of syndromes, carcinomas might be when they have not really presented in the clinical field, they are usually silent. And they're insidiously growing, and by the time they come to the clinical presentation, it's already unresectable. Insidious lesions that more often do not spread so fast, and they become unresectable in the primary area. And some of the tumors are very notorious. They spread fast, that is the adenocarcinomas. In some instances, chronic cough and expectoration might be the only feature, because you've heard of Yuvraj Singh having a mediastinal cancer, and the only symptom he complained was he was coughing a lot after some particular time when he was tired due to playing good cricket. And then he said that nothing much was happening to me except cough. I sometimes got prolonged bouts of cough, sometimes expectoration, but then attention is required, and of course some index of suspicion also, and you may see a mass in the X-ray, at least the non-invasive investigation you might be able to reach out to. By the time hoarseness, chest pain, superior vena cava syndrome or Pancoast syndrome comes into picture, pericardial or pleural effusion sets in, prognosis are already deteriorated. Becomes stage 3, stage 4 if there is already a pleural effusion. and persistent atelectasis or pneumonia happens, the prognosis drastically drops down at that time. By the time the clinical picture becomes severe, the prognosis drops down. And you know that what might be the effects of the lung? You may have pneumonia, you may have abscess, you may have a portion of the atelectasis, you may have pleural effusion, you may have, it can compress on your trachea and it will produce hoarseness, dysphagia, and compression on the esophagus will produce dysphagia. It can invade all the surrounding structures. Laryngeal nerve may be affected, it will produce hoarseness otherwise. Diaphragm may get paralyzed, it may produce because of the phrenic nerve involvement, and it may produce a destruction of the first, second rib or the chest wall it may destroy. It may invade into the superior vena cava syndrome, compress, and it may produce venous congestion, Horner syndrome due to sympathetic loss on the ipsilateral side and invasion of the cervical vertebral, the spinal cord of the encased cervical vertebrae, and then it can have pericarditis or a pericardial tamponade. It may produce so much pericardial effusion due to invasion that the heart is totally compressed and the pericardial fluid is getting elaborated in large amounts. Superior vena cava syndrome. So all this is the clinical picture of the tumors. And then you see that what exactly are the bronchial carcinoids? These are the neuroendocrine tumors which are on the benign end of the spectrum. And as I keep telling you, the neuroendocrine cells of the bronchial epithelium are incriminated and which are fancifully called the Kulczynski cells. So if you can remember, Kulczynski cells of the bronchial epithelium are the originators of the neuroendocrine carcinoids, and that line the bronchial mucosa, and it resemble the clinical picture is a well-differentiated neuroendocrine neoplasm, that is the looking like the intestine, the carcinoid. The neoplastic cells contain these. When you see this ultrastructurally in the electron microscopy, you see neurosecretory granules studied in the cytoplasm of these cells. And rarely they may secrete these hormone actives. So I told you that they are generally the paraneoplastic syndrome-like feature associated with these neuroendocrine tumors and secrete these hormonally active peptides. They occur as part of the multiple endocrine MEN1, MEN2 syndromes, multiple endocrine neoplasia syndrome. So bronchial carcinoids can become very notorious as the time progresses. The bronchial carcinoids appear generally at a younger age than the squamous and the adeno and the large cell carcinomas. So the bronchial carcinoids have a younger age. They start at 40, here the mean age is 40. So they're the ones which should be suspected in, let's say, a patient presenting at 30, 35, even as young as 25. They present in about 5% of all pulmonary neoplasms. So as you see, the picture is slightly shifted towards the younger age predilection. Look at this bronchial carcinoid going as a polypoid mass protruding into the bronchi, protruding a pale polypoid mass protruding into the bronchi. And a well differentiated zelbalan-like nesting pattern and very small looking cells with inconspicuous nucleoli, and you are seeing these cells, and it is a well differentiated end of the neuroendocrine spectrum, that is the carcinoids. The carcinoids, small uniform rounded cells, the well differentiated end of the neuroendocrine spectrum. So, and this is of course the lung tumor autopsy, and this turned out to be not a primary, it is a metastasis from renal cell carcinoma. So renal cell carcinoma below the abdomen can also send a shower of emboli to the lung. So lung is very notorious for receiving the metastasis from other organs. It's a large parenchymal organ. It's very notorious to receive these large parenchymal organs. Differential diagnosis should always be metastasis. Metastasis is in fact more common than primary. If you go test statistically, metastasis is quite more common than primary. So you should keep a very high index of suspicion that it might be a shower of emboli from elsewhere, especially if you see multiple. If you see these multiple nodules, you should keep an eye opener that there might be primary elsewhere in the. Why should you just take it as lung carcinoma if morphologically you see some other differentiation? Always keep a high index for other